So good afternoon, everyone. I hope you're getting a chance to get away from work and sit down for a little bit and think about QPS. We've got a great session for you this afternoon. So everyone needs a medicines list for safety, and how do we achieve this? So what are we going to look at in this session today? Well, I think as in our opening statement there, it's going to be about my medicines list and about medication safety. So learn how keeping a medicines list and the No Check Ask campaign can improve patient safety, gain some insights into the introduction of this initiative for vulnerable patients on an adult mental health ward in the Phoenix Care Centre, hear about the translation of the medicines list in over 50 languages, and launch of the new medication safety video, which is a step-by-step guide on how to complete your list and other resources. So you're going to take away lots of little nuggets from today's session, I hope, and I hope you enjoy it. So it's a pleasure to welcome our speakers today. My colleague, Ciara Kirke, who's HSE National Clinical Lead for Medication Safety. Ciara, you're very welcome. Good to see you. And Helen Danaher, who is the Chief Pharmacist in the Phoenix Pharmacy Department. So Helen, you're also very welcome to QPS TalkTime.
Thank you.
So Ciara, I'm going to hand over to you, and you're going to get us started on this webinar.
Great. Thanks very much, John. So yes, I'm delighted to see people from all over the country and working in many different services joining us today, and that's really brilliant. So this No Check Ask campaign and the use of a medicines list isn't news to many of you, and we're very aware that there are lots of people who are already aware of it. And it's actually been underway, being promoted for 5 years now, because we started in 2019. And we know that many of you are aware, many of you are promoting and using it locally, and lots of you are championing quality and patient safety and medication safety, and we hugely appreciate this. So we're really appreciative of that work, what you're doing, and are eager to support you in kind of progressing that further. So today is really a recap of a few important elements, and then Helen is going to share, a particular experience they've had using a list in her work setting. And then I'm going to come back and talk about some updated resources. And really, we hope through the chat and at the end that you would really share your experience and really learn from what you're doing, because sometimes we share information and resources and we're aware that things are happening, but maybe we don't hear about them as much. So it'd be great to hear from you in the chat and at the end. So I'm representing the National Medication Safety Programme, and we work with patients and healthcare providers to reduce, professionals and providers to reduce patient harm associated with medicines. And all of our information is on the website, the SaferMeds website, and we can be emailed on safermeds@hse.ie. So we're part of the National Quality and Patient Safety Directorate, along with my colleagues who host QPS TalkTime here. The World Health Organization have ascertained that medication is the most common cause of avoidable harm in healthcare. And that's a huge issue. So that is why medication without harm is the current global patient safety challenge. And that aims to reduce severe avoidable medication-related harm by 50% in 5 years. And the work that we do in the programme is also aligned with this. We're really trying to work with you to reduce harm. So World Health Organization have designated 3 areas as being priorities for action. And this is because they are associated with the greatest burden of medication-related harm. And that's medication safety with polypharmacy in high-risk situations, including high-risk medication, and transitions of care. They've also initiatives in different domains. So, leveraging the power of patients and the public to improve their medication safety and engage with the system to do so, supporting healthcare professionals similarly, the systems and practices of medications are really strengthening them to reduce medication-related harm. And then the medicines side, so the actual products and the information that comes with them, and, you know, trying to reduce the, you know, the naming, packaging and labeling issues that can trip us up. A lot of the purpose of the medicines list from a healthcare professional perspective is around trying to improve transitions of care. So with traditional medication history taking on some Irish research led by Thomasine Grimes in Trinity, found that 41% of patients will have at least one medication error or omission at admission to hospital, and that the rate is even higher at discharge. So these are not rare things. So our system performs in a way that is not ideal in terms of kind of getting the medication list transferred appropriately across the transitions of care. And we have very different information. So if we're a prescriber, we know we have a record of what we've prescribed for somebody. If we're working in a pharmacy, we have a dispensing record as to what we dispensed for someone, but we don't know about the prescriptions that never reached us because the patient decided not to fill them. At home, the person has decided whether to take that medicine as prescribed or take it differently, either intentionally or unintentionally to that prescribed, or to stop taking it. And neither the prescriber nor the pharmacy will have a record of that. The person, if they don't fill the prescription, will also not be taking it. And then there are over-the-counter medicines that people buy, and also, you know, vitamins and other types of products, which aren't recorded on a dispensing record in the pharmacy. So people can access other medicine and they may take them again according to the directions or variations of that. The real important thing to understand is that taking a better medication history, so trying to overcome the sort of figures that we saw in the previous slide, what the World Health Organization calls the best possible medication history taking. And it requires two sources, and both of them are really important because of what we saw on the previous slide about perspectives. So one of the sources has to be the person themselves. It's absolutely essential to understand what the person is taking, what their interpretation is, what they're using, how they're using it, because that's really important to their care. So people who use a memory aid, such as a medicines list, can recall and communicate their medicines more accurately than those who do not. So the medicines list serves many purposes, but it definitely serves a purpose of making it easier and quicker and more comprehensive to communicate at transitions of care. And also, it's not just admissions, it's at outpatient appointments, at any sort of appointment. It's a very quick and easy communication, and it facilitates communication. The second point is verification of that information, and that needs to be with at least one source of information which is known to be a more reliable source. So again, based on some of Thomasine Grimes and colleagues' research, we know which sources were better for use. So no single source of information is completely accurate for everyone. So you can never take a list and go, okay, that's it, I know exactly what this person is on. It always requires both steps. But the sources found to be more reliable were nursing home record for people who are transferring from a nursing home, contacting the community pharmacy, contacting the GP, or some hospital pharmacy staff will have access to the PCRS dispensing record to see what people have had dispensed, and that was found to be very accurate as well. Less reliable included some of the things that we do sometimes use, but to bear in mind that referral letters generally weren't very good comprehensive sources of information, patients' own drugs likewise, and where somebody had had a previous admission, that previous drug chart or discharge wasn't, judged to be a good source of information on the subsequent admission. So sometimes you might have to use those sources, but you would need to use additional sources and be aware of the quality issues. So again, 2 steps: the person, the verification, with at least one reliable source of information. And that's how you will improve taking the better medication history. So the medicines list, in very brief summary: everyone who takes regular medicines is encouraged to keep an up-to-date list of their current medication. It's both a self-management and a communication tool, and it should be shared with anyone involved in their healthcare and shared with staff at all healthcare appointments. So your role, for those of you who are health and social care professionals, making it easy to use, making it available, making it easy for somebody to pick up and access it, or sending it with appointments. When somebody does come to ask if they have a medicines list, ask at appointments, and then give it back, because it does belong to the person, and they'll need it subsequently to kind of manage their medicines on an ongoing basis. Thank you. Pass back to you, John.
Thanks, Ciara. That's great. And I think you've really set the scene there for us and introduced the idea of the list now. So I'm going to hand over now to Helen, who's going to maybe tell us about how this works in practice and her experience of using it.
Okay, hi everyone. Thanks, Ciara and John. Hopefully my little presentation will give how you apply it in a community setting. So my first slide there is about this medicines list. How do we achieve it for the patients that I interact with in CH09? So that's Dublin North City and County. So the Phoenix Pharmacy Department looks after a number of different inpatient and outpatient. We look after the Homeless Day Hospital in Ushers Island. We have a large clozapine outpatient dispensing service. We also look after patients that have intellectual disability that live out in the approved centre in St. Ita's Hospital. But my focus for this, my medicines list, was to look at the patients that are in the Phoenix Care Centre. So on my next slide, the Phoenix Care Centre is an adult mental health facility. It has 54 beds. There's acute and rehab patients in it. And the patient group that I focused on were the rehab patient groups. And what I wanted to achieve was for them to have an active medicines list, so that they would be able to bring it to other healthcare professionals that they interact with the objective outcome being safer medicines use for these patients. So why this patient group? Well, patients who have a severe mental illness like schizophrenia, they have a very high medication burden. On average, they'd be on over 10 medicines. And this would include medicines that are of high risk, like clozapine and lithium. They are more likely to develop comorbidities like cardiovascular disease. They're more likely to develop diabetes. The reasons for this really comes to do with the treatment. There are a lot of psychotropics that are prescribed for patients with schizophrenia. While they reduce the symptoms, they increase their functioning and prevent relapse, but they have multiple side effects. And these include metabolic syndrome, and there's lots of potential drug interactions. So on the next slide, it's just a little summary on what metabolic syndrome is. The antipsychotics that are typically prescribed for people with schizophrenia can lead to visceral obesity, insulin resistance, and therefore increase their likelihood of developing diabetes. They can get hypertension, and then they have problems with their cholesterol levels. Their good cholesterol, their HDL is low, and their triglycerides are often quite high. And this leads to a high medication burden. Not only are they on medicines for their mental health, but they're on medicines for diabetes and cholesterol and for blood pressure. And on my next slide, you'll just see how do you bring about a model of change like introducing a My Medicines list. Well, for me, it was about creating awareness. When I heard about this, I thought it was really applicable for the patients that live in the rehab unit in the Phoenix Care Centre. So I would have brought it to the multidisciplinary team meeting and got a desire from the pharmacists that work here in the team to look at giving the knowledge to the patients that are there. With mental health illness, you can have a lot of cognitive impairment, and their ability to be able to fill out a list like this is very limited. So it was like, how do we bring about this model of change so that we can get the list for everyone, and how do I reinforce it? So on the next slide, you'll see that from bringing the awareness to the staff, and a lot of the staff were really well behind it, the nursing staff that look after the patients all the time, they thought it was a great idea, because the patients that I'm talking about in this hospital, they're out and about all the time. So they're going to GPs, they're going to hospital visits to see other consultants. So they interact with dentists, they interact with lots of other healthcare professionals. So the completed lists were done by the pharmacists, and then they were given to the patients. And it was encouraged that if they interacted with any other healthcare professional that may be involved in prescribing anything for them, it could be to the dentist, it could be to a respiratory consultant, that they bring the list with them. The reinforcement for this list was done at MDT. So that's the multidisciplinary team meetings that happen. In mental health facilities, it's slightly different to acute hospitals. MDTs, the patients in mental health, they attend them. So they're sitting in at the meeting, talking about their individual care plans, discussing their goals, etc. And here the pharmacist will remind them, have you got your medicines list? Did you bring it anywhere with you? Have you lost it, so that we could give them a new list if they needed it? Did you bring it when you were going to the GP? So it was about that reinforcement, so that the patient could take some responsibility for their medication needs. There's lots of challenges for patients in long-term settings, and as Ciara alluded to, the WHO and the challenges of reducing medication without harm, one of the parts of it is about public awareness and medication literacy. So I felt that patients having this medication list would improve their literacy, because there can be, with patients long-term, in long-term settings, they can have cognitive impairment, they can have particular behaviours, and then they have a very fixed relationship with the clinicians in that setting. But then that changes when they go see other clinicians, you know, that there may be an assumption about how they look after their care and what they know about them. So why this medicines list really, as I said, is so important for the patients in long-term settings like Phoenix Care Centre. So I alluded that they're on high-risk medicines, including clozapine, lithium, and depot antipsychotics, and some of them are very hospital-specifically dispensed, so they wouldn't necessarily know in other settings that they were on this medication. And these patients interact with GP practices, so there is problems with transition to care, drug interactions, and correct medicines reconciliation, and the same is mirrored in the acute hospitals. And again, as I said, these patients, they live in the hospital, but it's like their home, and they go in and out to the acute hospitals, to settings, and it's really important that they have a very current active list of their medicines. The high-risk drugs, and Ciara alluded to them as being one of the other challenges that the WHO is going to focus on. One of them that we would interact a lot with is clozapine. So attached to the My Medicines list, I stapled on a little card that comes from CPMS and the Clozaril Viatris company, which highlights the patient's name and their CPMS number. So CPMS is the Clozaril Patient Monitoring Service, and what it does is it looks after the bloods for the patient. So Clozaril, as a high-risk drug for schizophrenia, requires monitoring because there's a risk of agranulocytosis and neutropenia with it. So you need to get your bloods done frequently, and then you get a red, amber, or green light as to whether you can get supply of the drug. So on this card, we would have the care coordinators, that would be the nurse lead that would be looking after the patient, who the consultant was, and the telephone number for the unit of where the patient was. We would also put on the back the alternative contact as ourselves, as the pharmacy that supplied the Clozaril, because if this patient goes into another hospital, they would need to know where they got their supply of clozapine from. So you can see that our service users, or our patients, they attend multiple healthcare settings, and this is why it's so important that the moments of medication safety are adhered to. If somebody starts a medicine, adds one in, reviews it, or stops it, it's essential that this is captured in a timely fashion so that there isn't any errors, like as Ciara was saying, in transition of care between places. Now, I'll just show here, this is an example of what a typical patient of mine would be on. So you can see that's quite a number of meds for somebody to remember, even if they had full cognitive function to try and list. I find that challenging myself, to be able to remember the names of all those medicines. So it is really useful to put patients like those with severe mental health problems on the same footing as the person so that they can get asked in the same way as Ciara was saying to, you know, ask a patient about the medicines that they were on, that this person can say, look, this is a list that was done by my pharmacist in the hospital where I am. So we fill out a date time on it. So it's from that date, this is the medicine that I was on. So it's very time stamped, and it does require verification with another source, but you would have on the other side the unit that the patient was in the hospital that they were staying in. But you can see here that they tend to be on and multiple numbers of drugs like PPI, stuff for their cholesterol, stuff for their blood pressure, and vitamin D. The clozapine there is written in, and also the clozapine card is attached. Wells is very commonly prescribed for somebody who's on clozapine because they get hypersalivation. Metformin would be commonly prescribed, maybe for weight gain, but also for possible diabetes. And a lot of the patients that are on clozaril are smokers, and they tend to have COPD, and they're on inhalers. And the inhaler names are very challenging to remember, so it's good to have them written out on a list that makes it much clearer. So the next slide just highlights how we did it. So we got the pharmacist to complete the medicines list for the patients, and we have encouraged them to bring them to other healthcare professionals. So when I spoke to the patients myself down there, I said, now remember, if you're interacting with anyone who's going to be prescribing anything to you, make sure that they see your list so that they know what medicines you're taking. And I suppose from a sustainability point of view, we're lucky in our pharmacy that we attend the multidisciplinary team meetings that are held every month. So if there was an alteration to the medicines list, we would note it, because the pharmacists keep a copy of the list that was handed to the patient. And then if there's an update or change on their MPAR or their Cardex or administration Cardex in the hospital, we'd be able to update their list and give the patients a new list, which is another re-emphasis and reinforcement of the list to remind the patients and to engage with it. There's lots of future applications for this. I think the high support and medium support hospitals, where a lot of service users live in the community, it'd be really applicable to do this. My final slide is just a little summary one on why I chose the Phoenix Care Centre. Is that these patients are unique in that they interact with multiple healthcare professionals, and from a patient safety point of view, it's really advantageous for them to be on the same footing as everyone else, and to have a medicines list, for them to be educated about their medicines, in the hope that it would improve patient safety and it would achieve the goals of improved medication safety, better quality improvement, and better outcomes for the patients, that they don't end up in a situation where they're in hospital and one of the medicines that's crucial is left off because of an inaccurate med record. And I think that's me. Thank you.
That's great, Helen. Thank you very much. Can I just ask you, how, I mean, did you have many barriers or difficulties in implementing this?
I suppose the challenge really is the sustainability bit, and the emphasis that it isn't to replace medicines reconciliation. So originally, when you know, the initiative came out from errors in transitions of care between GPs and that not having accurate lists, that it's to make sure that it's time stamped on that time, and it's a communication piece to contact the pharmacy or to contact the ward where the patient is to get an accurate list. That it isn't an automatic list, as Ciara was saying, but it gives it's very challenging for the patients to remember the names of all of those drugs, and they won't. So it gives them a little bit more information armed with when they go to see other healthcare professionals.
Great. Well, thank you. And I think we're going to come back and we'll have some questions, and I'd be keen to see what the all our listeners are thinking about this as well. I'm going to hand back to Ciara for a few moments, who's going to maybe talk about some of the resources and things that we can do to get this more widely into practice. Ciara.
Great. Thanks, John. And thanks, Helen. That was great. So I'm just going to kind of recap on some of the things that you can do. And I'm aware that lots of you are doing a lot already, but just to give you a recap on some of the resources. So the first one is the other side of the No Check Ask campaign. So we have really focused on the, people knowing their medication, checking the details and asking healthcare professionals if they understand. But there's also the 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 staff side of knowing any medication that you are prescribing, dispensing, administering, and checking the details so that you have the right patient route, medicine, dose, and time, and then engaging with the patient and making sure that they understand and that you're fully communicating and identifying any safety issues. Sorry, Chris, back another little bit. In terms of medication without harm overall, there is a really good course available on HSE land and also on the Irish Institute of Pharmacy for those of you who are pharmacists. But this takes about an hour and a half to do. It's an introduction to medication without harm, so covering all of the areas involved in the World Health Organization challenge. It's very accessible for all members of staff, and it really helps people to understand different perspectives, so perspectives of different patients, carers, family, service users, and then of different healthcare professionals working in different care settings. So it kind of gives an understanding of medication without harm overall, but also a focus on transitions of care and polypharmacy and high-risk medicines. And the list and that information is pretty central within that. So with the No Check Ask campaign, RCSI have done an evaluation of it, and there's an awful lot of information that has been gained from that. But so just to summarize some of the things that are relevant in understanding where to go from here, from the publication that I'm showing down there. So people are very positive. So this is both healthcare professionals in different care settings and health and social care professionals, and also people in the public. Very positive response to the message and also to the materials that have been developed. Then and still, we know that the big challenge is that people have a limited knowledge and limited awareness of either the campaign, but also of the purpose and value of using a list. So people, once it was explained to them, were in very profound agreement that it would be beneficial, but a lot of people weren't aware of it before, or aware of just the usefulness of keeping a list generally, even if it was nothing to do with this campaign. So people do use lists, and they are used in a variety of situations. So there's a lot of information within the findings about how people use their lists and what prompted them to do so. And really, the biggest drivers for use were once people had more complexity with their medication. So when people started going up to having larger numbers of medicines, it became more complex. And also if multiple people were assisting, so where maybe if somebody had cognitive issues and other family members or carers were assisting with that to try to kind of increase communication among them. And also people who were concerned about emergencies. So what happens when if you are suddenly admitted to hospital, or those sorts of things, and those became drivers for use. The concerns people had, so both groups, patients of the public were concerned about accuracy, and healthcare staff as well. Healthcare staff cited time constraints as limiting their ability to support people with the use of a list. And I think that is important. So when we were addressing the campaign, we were really saying that this is for self-completion, and that people can complete it with the assistance of family members or carers or people who assist them with their health generally. But also, as Helen has illustrated very well, and we know other services have supported staff. So in some cases, it does fit very well with how the service is delivered, and staff can support people with the list. the ability, and people also had concerns about those with more medicines or with cognitive impairment to manage. And again, with cognitive impairment, all the more reason to have a list, but that list, people may need assistance to put that list together and to keep it up to date. The facilitators in this, I suppose, is very important and very timely, because I know people have been raising this in the chat. So promotion of the use of a list by healthcare staff is a big facilitator. So both in our study, but also in another study in the UK, if a healthcare setting is encouraging the use of lists, people are more inclined to use them. And access to digital or compact lists. So I suppose the paper version of it, you're writing quite a lot of information, and so it's quite hard to make it compact. But the use of a digital list, it has been raised throughout. We didn't have the resources to develop an app to date, but the HSE app project is underway, and they are going to incorporate a self-compiled medication list as part of that app. That will probably be, so it is, it's very much in development and with piloting in maternity services this year. But I would say it is a very active project, so it will probably be live in 2025. The health passport for people with intellectual disabilities as well. So they're looking at updating that to incorporate a list. And again, as with the situation Helen highlighted, for people who are less able to articulate or to remember their medicines, this is really important information for them to be able to share. So next slide, please. So we spoke about accuracy there, so the concerns about accuracy. And again, I think this slide can't be focused on enough. We're talking about two sources. So we are talking about all sources. So there being a process to taking a medication history. So what we're doing is getting the person's account and getting a reliable source of information to give us another account, and putting the two together, speaking to the person if there's discrepancies, and trying to come up with the best possible medication history. So again, no matter how brilliant our lists were, it's still not going to be completely accurate for everyone. And so it does always require those two steps. And what the list does is aid the person to communicate and recall their medicines better, and therefore that assists at transitions. So back to resources. So we have an absolute wealth of resources on the SaferMeds website, so hse.ie/SaferMeds. So it's under No Check Ask for your safety. The Get Started tab has information which is geared towards patients and the public and family members. Get Involved is geared towards healthcare professionals and people working in health and social care services. And that's really to kind of get involved in trying to promote and support the No Check Ask campaign and the use of a medicines list. And then we have a load of resources. So on the resources tab, we have lists, we have posters, and we have videos. So Grania Mloy, who is pictured here, has spent the last couple of weeks painstakingly transferring translations onto the medicines list format. We were hoping, we are launching them today, but unfortunately we don't have them up on the website yet, because there's a bit of work that HSE comms digital have to do to make sure that we get them onto the website properly. But basically we have translated them into over 50 languages. So they are done now, and they will be available soon, so within the next couple of weeks. So with some of the QPS correspondence, we will send the update when they are available. And sorry, just back on the previous slide, what we do have is we still have vast quantities of the lists in English. So if you are interested in promoting this or using it locally, you can order lists in any quantity you want from healthpromotion.ie. And when you go on, if you sign up for an account, so if you don't sign up for an account, I think you can order up to 20, but if you sign up for an account, you can order any quantity you like, and that is all free. So we would greatly welcome you ordering and using the lists. So even with the translations, it may be that you would have the lists in English, but that you would be able to go online and help somebody to access the information in their own language, for example, on their phone in a few weeks. So our other resource, which has been updated, so Chris, who is behind the scenes here, and Grania have been working on developing a video, which we're going to share now.
Do you take medicines? A medicines list can help anyone who takes medicines and those involved in their healthcare. It can allow better and faster decisions to be made about your medicines and reduce the chance of error. How do you use a medicines list? On your medicines list, fill in the name of each medicine you take, how much you take, and when you take it. Make sure you include all of your medicines, such as tablets, inhalers, injections, patches, eye drops, and creams. You should also include medicines you get in your pharmacy, such as vitamins, supplements, herbal medicines, alternative medicines. Include any allergies you have. Include the contact name and telephone numbers of your doctor and pharmacist. If you need help filling in your medicines list, ask family members, friends, or people who support you. You can also ask your pharmacist or GP to print out a list of your medicines. Remember, keep a copy for yourself to keep track of your medicines. Keep it where you can easily find it in an emergency. Keep a photo of it on your phone. Bring it with you to any healthcare appointment. Bring it with you when requesting repeat prescriptions. Share it with family and friends, your doctor or consultant, your pharmacist, dentist, or nurse. Your healthcare team may not have this information. Health records don't currently link up. For more information and to get a free copy of a list, visit www.hse.ie/safermeds.
So just to recap some of the suggested actions, enclosing a blank list with appointment letters or in admission or discharge packs or any kind of routine process that you have is really good. In some settings, they've just printed the kind of inside page, the list page, onto the back of an appointment letter or other correspondence. Displaying posters and videos, if you like it, in waiting rooms or in public areas, and making those blank lists available. So we can be contacted. We do still have some posters to send out, and we're happy to send those out. If required and if possible, facilitate that residents and service users would compile, so either that they compile and maintain their own list with the support of family or with your support, if that's possible in your service. And then something I know that people do very widely, it's always lovely to see on social media when people are promoting the medicines list and no check ask at public events, and promoting those things plus the e-learning at staff events would be very positive. So again, in doing all of this, we're joining with our colleagues around the world in trying to achieve medication without harm.
Thanks, Ciara. That's great, and I love the video. It's lovely and clear, and I think one of the principles of QI to me, is in complexity. I think it's trying to propose simple solutions sometimes, you know, that they're not simplistic, you know, but you know, solutions that understand really the root of the problem, and so I think you've given us some lovely examples of that. I'm going to hand over to Juanita, I think, who's been keeping an eye on the chat there, and maybe might have some questions for Ciara and for Helen.
Do indeed, and thanks very much for that. There's a huge amount of information shared so far. Some of the questions are quite technical, and then some of them are a little bit more complex. So we'll do our best. But I suppose the first one there, just Owen has asked: is there a version of the PDF that can be edited, or a Word document? It might make it easier to simply edit the list rather than writing anew after multiple changes.
There is one on the website, so it's just a Word version of the document.
Great.
We're aware that it hasn't really been used, so I don't know if that's due to lack of awareness or what it is, and I suppose it still needs to be printed out. So I think in practice, people often find it easier to have written out one, which they can then put a line through. If they're in an appointment, you can kind of highlight what drug we're talking about and make the changes onto that. So I think, yes, the apps are coming, as we were saying, in which case you can update them on it. But I suppose the paper is really quite useful, and it's always accessible, and it never, you never lose contact with your paper. So it's just a case of having it. The other thing, in order to have it portable and with you, is taking a photo of that list, or people sometimes prefer to take a photo of each of their drug labels, each of their packaging labels.
Okay.
With the instructions.
I think for a lot of people it's easier to take the picture, and then the question is, do you actually take what you're meant to take when you as it's been prescribed? I think for a lot of people that might be the big thing. There is a question here as well about the need to transcribe the list onto a piece of paper, introducing the potential for errors. And I know that you've touched on that, the idea of the HSE app project, and that there is the work in progress at the moment around that. But is there a double checking recommendation around people filling in the lists, or do you give people advice on double checking the list when it's complete?
I think this really comes back to your medication history process. So again, you have two sources. You need to look at two sources, and one of them is the patient's account. So that patient's account is the patient's account. It will provide you with information that another list can't provide you with. So as we talked about, if people are taking them differently, you won't know that from your other sources. So for the HSE app, we're discussing this because there are healthcare sources of information which will give you a list. So people can and do ask in their community pharmacy for a list of meds. Say if they're going to be going in for an elective procedure, they'll ask for a list of their meds, but that doesn't include what the person is doing with them, and it doesn't include the outpatient information. So both things are important, and I think that's what's really important to understand. None of these sources is perfect, and what you're doing at that transition is trying to get the best possible information. But that best possible information, no matter what we do, if we have a national electronic health record, we're still going to have to talk to the patient. So this handheld information is an aid for the person to better articulate what they're taking.
Okay. And just Bernie had a question. Bernie Chapman came in just to see how could it be achieved for those with multiple prescribing service providers. And I think she was referring to the piece of work with Helen in particular. If you've got multiple sort of service providers prescribing, are there thoughts on that, or had you given consideration to that in the work that you did, Helen?
Well, yeah, I think that's really kind of what sparked the initiative for me, and the importance for the patients to have some sort of a list when they go to other healthcare providers, because it comes out of errors in patients going from the Phoenix Care Centre to the GP and then getting admitted into an acute hospital, and the list getting made, like as Ciara said, from the previous admission when they were in hospital. But that's not the full list of their medicines. And the huge importance for me is the likes of clozapine or lithium, the high risk drugs when they're left off. So when you do have multiple inputs, it can make it really challenging. And for the patient to be that person, like as Ciara said, the person that you go and talk to and ask, should be the same for patients with mental health difficulties. Go and ask them, because in lots of cases, they will know a lot about their medicines. They mightn't remember all the names, but if you said to them, oh, you're on something for schizophrenia, do you take something for your blood pressure? It's very likely they'll know, you know, and, or are you on an inhaler? They won't remember the name of it, you know, because they're difficult enough names to remember. So yes, that's why I think it's so important, because when they go to the GP, they won't always necessarily have, the GP won't necessarily know if there's been changes in their meds from the last time they were in the acute by the psychiatrist. So it's a really good idea for them to, when there's multiple people involved, for there to be a list that can then be, you know, made sure that it's correct. As Ciara said, you go and you check with the other health, check other routes, but it's one piece of information they have.
Okay, thank you for that. There's a few questions coming in about the risks of the process, you know, and you know, were there many risks identified in relation to transcribing the list by or for a patient? And a few of them sort of have talked about if friends or family fill in the list and, you know, showing they're non-regular healthcare professionals, could there be a risk of abuse if there's drugs with a street value, for example, diazepam or opiates? You know, and that there's other questions there in terms of GDPR, you know. Maybe you might like to talk a little bit about consideration that might have been given to some of those risks. I'm sure that you've addressed them all in some shape or form in the preparation of it.
It's an interesting one because, yeah, I think, well, certainly from a pharmacist perspective, working in any community pharmacy, you're always very alert to the listing of any of those medicines. This is not a prescription. You're still going back to the thing, you have to do your medication history. So you're not transcribing the diazepam 10 milligrams twice a day from this list. You are taking this list, you are taking the information from the person, and you're finding out the reliable source of information, and you're putting that together to work out you know, what to do at that transition. So I guess there could be a risk of abuse, but you really have to do your process. So you have to do your medication history, medication reconciliation process. Yeah. So
and I could understand the risk.
Yeah.
Yeah, no, and I could definitely understand the risk if somebody was maybe in the local community and their name is on this and they dropped it and somebody found this list that had very personal information in about it. So
Yeah.
I suppose I could see, you know, the concerns that would be there in that space.
Yeah, and I suppose you are, though, I mean, it is held by you and it is shared by you with the people that you wish to share it with. So yes, it's you know, it's very confidential information, but it is held by you. So we're not sharing that outside of that fact, and it is important as well to give it back. So I think if you are taking a copy of it for records or using it in order to inform what you're doing, you do still give it back to the person. Or kind of, if everything is changing, you're giving them back a blank list to go and kind of start off an update of it.
Yeah, that personal responsibility is always going to be there. Yeah. And there was another piece here about, you know, frequently, you know, patients being discharged from an acute setting, but might run out of space because of the polypharmacy and in particular with elderly patients. I'm assuming in a situation like that, you know, the question is there any plans to increase the size of the list? You know, can we connect two lists together, or thoughts on that?
Yeah, so we took feedback. So the first version of it had more information on the inside page, and we moved some of that to the outside page in order to give more lines. So I think there's maybe 14 lines of medication now, which is too little for some people. So yeah, you'd be attaching two together.
Yeah,
I on both of them. Yeah.
A couple of patients that we completed for, like, I mean, the fictitious list that I did up, it was not, most of them filled the whole page plus half of another.
Wow, okay.
So they would all be on a lot more than what I would have put down. So yeah, we just clip them together.
Okay. And there's an interesting point there from Eugenie about if the list is too long, it might be an indication for a review for polypharmacy, and there could be something, beneficial in that.
Yeah.
There is a piece about literacy coming through, and it's come through from a few different people and how we might support them. And I know that one person had mentioned about using visual aids. I don't know if you want to maybe touch on that before we go back to John, because I'm conscious we have 2 minutes left, and we could probably be here for the rest of the afternoon with the discussion going in the chat.
Yeah, I mean, I suppose there's an attempt to be a little bit visual with the type of medicines, but I suppose the work for the health passport is for people with intellectual disability, but I think it is largely for completion with assistance, really.
Okay.
I suppose as well, and I'm just seeing one of the comments there, yeah, so there are risks if the person isn't medication literate or cognitively impaired, but that risk is greater if you have nothing. So if you have nothing versus if you have a list. So yes, you may be wary of what's on the list, but if you have nothing out of ours, that's going to be even more challenging.
Yeah.
And that's where I kind of came from as well, in that the list, if it was there and it had clozapine on it, that it alerts the other healthcare professionals to say, oh, I need to check this. So, but as Ciara said, if you've no list, and then you're totally in the dark.
You're starting from scratch.
And I think as well, in terms of the kind of empowerment thing, or Eugenie's comment about indication for review of polypharmacy. So if somebody is filling this in and they're going and checking all the details and they're checking, oh, why was that started? It is a prompt as well for people to kind of consider whether, or discuss with the healthcare professionals whether any of this needs to be reviewed, or any of it needs to be changed. Do I still need to take that? Those sorts of discussions are facilitated by the use of a list.
Brilliant. Well, thank you so much. I'm going to pass back over to John, but thank you both, and thanks to everybody for all your questions.
Yeah, well done, everyone. Great discussion, and like Juanita said from the chat, we could keep going. So I think we've certainly got people interested. I think it sounds like digital will come and will have a big effect and be very helpful. But for now, paper is here. Paper is useful, and I think it's up to all of us in the QPS community to promote this. To make patients and our colleagues aware. Because it is a very useful tool. So let's get doing that. So you can follow us on, we said earlier, on social media. You can watch back today's webinar. It'll be up in a few days' time. This again is just an ask for people. We are developing currently a quality and patient safety competency navigator. I'm involved in this project myself, and I think it'll be a fantastic resource. But one of the things we're keen to do is really co-produce it with everybody out there. So this is your chance to co-produce. So we want you to get involved in giving us your feedback, to use the navigator to see, does it do the things that we think it should be doing. So there's a QR code link there, please, if you have some time. It is 45 minutes we're asking for, but I think it would be nice to get your input into this so that we know that we're developing the right kind of competency navigator for everybody. So please, if you have the time, do that. Let us know how we did today. Again, you'll get a chance to give us your feedback at the end of the session, or you can scan the QR code to join our mailing list, and you can give us feedback there as well. So it's been a pleasure. Thank you, Ciara and Helen, and thanks again to Juanita, who do all the heavy lifting in the background. And I look forward to seeing people on the 28th. So thank you. Goodbye.